Well, hello everyone. My name is Dr. Alex Deegan and I am a senior lecturer in the School of Law here at the Queensland University of Technology, and I'm the coordinator of the QUT Global Law, Science and Technology Seminar Series, which brings together national and international speakers who explore the personal, societal and governance dimensions of solving real-world problems which are influenced by and through the interaction of science, technology and the law. I'd like to officially welcome you all to today's seminar. It's so pleasing to see so many participants from both the profession and universities all around the world. This final seminar of our series in 2020 is Patient Rights and Healthcare Decision-Making After COVID-19, Transformations and Future Directions, presented by Professor Thaddeus Mason-Pope. You can find an abstract for the seminar in the information for this event. This seminar is co-hosted by the Australian Centre for Health Law Research, and so I'm going to turn it over to Associate Professor Tina Coburn, who is the Director of the Centre, to say a few words. Thank you, Tina.
Thank you, Alex. Greetings, everyone, wherever you're joining us from around the world. I'm Associate Professor Tina Coburn, and with Associate Professor Fiona McDonald, I'm a co-director of the Australian Centre for Health Law Research, and I'm delighted to welcome you all to this edition of the QUT Global Law, Science and Technology Seminar Series, which the Australian Centre for Health Law Research is very proud to co-host. And I'm delighted that Professor Pope, one of our esteemed adjunct professors, is delivering today's seminar. Before I begin, in keeping with the spirit of reconciliation, I acknowledge the traditional owners of the land where QUT now stands. I pay my respect to their elders, past, present and emerging, and acknowledge the important role Aboriginal and Torres Strait Islander people continue to play within QUT. Before we start this seminar, if I may, I'll just make some brief comments about the Australian Centre for Health Law Research. Our research group is comprised of some 28 academics, a large growing cohort of PhD students and esteemed adjunct professors. We're also supported by an outstanding group of research assistants who work with us on various projects. It's exciting to have all this critical mass, all these people working together on challenging and important health law issues. Our research in the Centre spans the health law field from the beginning to the end of life. We have 4 programs: End of Life, Healthy Ageing, Health, Society and Regulation, and Technology, Innovation and Health. We'd welcome the opportunity to discuss the research we're doing in the Centre and the possibility of collaborating with you on various projects. Our researchers are leading debates and investigating the laws, policy and practice in these areas. An important goal of the researchers in our centre is undertaking the research that has an impact, that makes a difference. We do this in various ways, and of course we undertake traditional research and publish our findings in scholarly journals, but we strive to do much more than that by translating the results of our research into improving the quality, safety, accessibility of healthcare in Australia and internationally. Research alone is never going to make that happen. We really need to bring our research out into public and policy debates. And of course, these sort of online seminars form a very important part of that goal. So it's now my absolute pleasure to invite Dr. Alex Deegan to introduce our colleague, Professor Pope. Thank you.
Thank you, Tina. Professor Thaddeus Mason-Pope is a bioethicist and Director of the Health Institute and Professor of Health Law at Mitchell Hamline School of Law, with an extensive list of publications, citations and influence in the health space. And as already mentioned, he is an adjunct professor with the Australian Centre for Health Law Research here at QUT. The format for this seminar will be as follows. Professor Pope will speak for 30 to 40 minutes or so, and this will be followed by a structured Q&A, which I will chair. For the Q&A section, if you wish to ask a question, there's a few options for you. You can select the participant bar at the bottom of your Zoom screen and select yes or the green tick in the participant window, or select the button to raise your hand to indicate if you wish to ask a question. or alternatively, you can post in the chat, which I will receive, and then on your behalf, I will relay that question to Professor Pope. So I'll act as chair and pose the question or call on you to ask a question, and then Professor Pope will respond, and then so on and so forth. And of course, for this seminar, I would request that you adhere to the usual Zoom meeting etiquette by keeping yourself muted, unless you are speaking or asking a question where I may call on you. So thank you very much, everyone, for being here today, and I'll pass it on to Professor Pope.
Great, thank you, Alex. So I'm going to share my screen now. All right. So thanks really very much for having me. It's a pleasure to be part of this series. I got a chance to watch the previous episodes. And as you mentioned, it's been a pleasure to work with QUT law faculty for years on a number of different issues, from VAD to brain deaths. You know, so for years I got to work with Ben White, Wendy Wilmot, Eliana Close, and Andy McGee. And in fact, just this week, there's another seminar that I think QUT just posted, where Ellie and I talk about voluntary assisted dying. So it's a pleasure to have yet another opportunity to interact and participate with QUT Law. So let's get started. So I'm going to start with COVID-19. And when you look at the media, you see a lot of people describing us as being at war with the coronavirus, right? That's the metaphor that's used, war. You see this used by New York Governor Andrew Cuomo, by President Donald Trump, by the French President Emmanuel Macron, by the Prime Minister of India, by the Director General of the World Health Organization, by the Premier of West Australia, and by the Prime Minister of Australia, right? Everybody is using this metaphor, at war with the coronavirus. Why do they use that metaphor? Well, it conveys a sense of urgency, right? By saying that we're at war, it turns an issue into the issue. And what I want to do in the half hour here is build on this metaphor of war. And I want to build on this metaphor in the context of clinician-patient communication. And so in my abstract, I listed 3 questions. In what ways has COVID-19 changed how clinicians communicate with patients? In what ways has it changed how patients make and record healthcare decisions? And will these changes persist after the pandemic? So I'm gonna, this is the roadmap for tackling those questions. It's also in 3 parts. So first I wanna just go back and analogize and look at innovations during World War II and how those persisted after the war. And then to analogize and turn to innovation during the time of COVID-19. And specifically, what I want to look at is advanced care planning and patient decision aids. And then talk about whether those COVID-19 innovations should and will persist in the same way that innovations during World War II persisted after that war. Okay, so World War II, right? This year in 2020, we celebrated the 75th anniversary of the end of the war, right? There were a lot of ceremonies and memorials. There were a lot of special television programs about this. And one thing that we were reminded of in celebrating the 75th anniversary of the end of the war was that there was a lot of technological innovation during World War II that was sort of driven by the war needs. And so, you know, some examples, right? During World War II, most of the world's rubber trees were under the control of the Japanese Empire, right? But we needed rubber for planes and jeeps and lots of other things for the war, so we invented synthetic rubber, right? And we still use that today in lots of things like our car tires. We also invented penicillin during World War II, right? To deal with all the infections from battlefield injuries. And still today, penicillin is perhaps the most widely used antibiotic. We invented the pressurized cabin, first used with the B-29 Superfortress during the war, and of course, still used today with jet travel. Cavity magnetron, first used for radar to detect German planes coming to Britain, but now used today in your kitchen microwave oven. Bletchley Park in England, which was the headquarters of the Allied code breaking effort, where we built the world's first programmable digital electronic computer, which of course is the ancestor to your laptop today. Super glue, the slinky, silly putty, and duct tape, right? There's a lot of stuff, right, that came out of World War II, right? We really see that necessity is the mother of invention. And moreover, not only did we invent all these things during World War II, but all these things are still used today. So I want to look at COVID at the time of COVID-19 and ask similar questions, right? Is the same thing true, right? Are we innovating during the time of COVID-19, and will those innovations persist after the pandemic? What innovations are there? Will they persist? So you get a lot of reports, about how many infections there are and how many deaths there are. It's really depressing, sad data that we get every single day. But there is a silver lining to that dark cloud, and that is innovation. So there are some bright points. Now, perhaps the most, in the healthcare space, perhaps the most salient innovation has been in telehealth, right? More and more patients aren't going to a clinic or to a hospital, but are getting diagnostic interventions or even treatment interventions through their computer or their phone. And so the growth in telehealth is tremendous during 2020. But what's even more notable is that's expected to persist even after the pandemic. Both patients and clinicians report that they plan to use telehealth a lot more even after the pandemic, even after there's no social distancing need to have a telehealth visit. They're still going to have a telehealth visit because it's more convenient. Well, I don't want to focus on telehealth. I just wanted to acknowledge that probably is the biggest example of technological innovation. What I want to focus on are tools for medical decision-making. And these are COVID-motivated innovations. And what I really want to focus on after introducing them is whether or not they will persist after the pandemic. So all the tools that we're going to talk about are basically tools that are designed to address this problem, which is the problem of value discordant healthcare. And what I mean by value discordant healthcare is the problem that patients get treatment that they don't want, or they get treatment or they don't get treatment that they do want, right? Or another way to describe the same problem is it's the problem of over-treatment and the problem of under-treatment, right? They're getting treatment, it doesn't match up, right? The treatment patients get doesn't match what their preferences and values are. Now this happens, value discordant treatment happens to patients with decision-making capacity, people who can make and communicate decisions on their own behalf. But it happens a lot more to incapacitated patients who can't speak on their own behalf, right? Because they can't tell us what they want, and they can't tell us what they don't want, right? So if you take a patient with COVID-19 who's on mechanical ventilation in a hospital ICU, right, they're sedated, right, along with the mechanical ventilation. So they can't advocate on their own behalf. Now, the key tool that we have to mitigate value discordant treatment for incapacitated patients like those on mechanical ventilation with COVID-19 is the advanced directive, or the advanced healthcare directive, right? Basically, right, where the patient has written down, these are the treatments I would want, and these are the treatments I would not want if I can't speak for myself. So what's been happening with advanced directives? Well, before COVID-19, the situation did not look very good. So if you just look at some data from the United States, for example, the Pew Research Center had done a study, and it found that basically only 35% of Americans have completed an advanced directive. Now, even if you drill down and focus just on those people who are 75 years and older, in other words, the population for whom an advanced directive is most likely to be relevant, because they're going to be most likely to be incapacitated in a hospital, even then it's barely more than 50%. There's another study, this is in Health Affairs, which is a really big study. In fact, it was a meta study, a systematic review of 150 other studies with 800,000 people altogether as the sample size. And they found that the advanced directive completion rate in the United States was 37%. If you look at Australia, it's not even that good in Australia, right? If you look at some of the recent reports on advanced directive completion rates, like this report, they put the completion rate at just 25%. And it's even lower than that in the UK. So things were not so good in terms of advanced directives being used to avoid value discordant treatment for incapacitated patients. Why is that? Well, we don't think about death, right? We don't like to think about death, so we don't plan for our death, or we don't plan for end-of-life treatment. And that's not the only reason, as we'll see, but it's a key reason. In fact, because we don't think about death, people actually developed phone apps like We Croak. And this is such a simple app. All it does, if you download this on your phone, is 5 times a day, it sends you little reminders that say, hey, don't forget, you're going to die, right? And it does that 5 times a day, every day, just to put that into your consciousness so you start to live your life with that in mind. Now, of course, during the time of COVID-19, we don't need that anymore. We don't need the We Croak app, right? We don't need that kind of reminder in 2020. We are already thinking about death a lot more than we used to, right? Every single day on the news, we get all sorts of reports about how many infections there are, how many deaths there are, and and things like that. At least here in the United States, in a large number of cities, we have trucks parked out on the street, refrigerated trucks filled with corpses because the morgues are full, right? So we're reminded of death more than we even want to be. But the consequence of that is, since COVID-19, advanced directive completion is way up. And that's a good thing. So we have lots of reports from legal publications that the pandemic has increased a focus on estate planning, increased a focus on healthcare directives. The demand is rising. And this has been measured in a more, this is not just anecdotal, it's been measured in a more scientifically rigorous way. So one study found completion is up 400%. This is a study from West Virginia University. Another study found advanced directive completion rate is up 500%. And this was a study published in JAMA out of the University of Pennsylvania, where they looked at advanced directive completion using a particular tool that's downloadable on the web before COVID-19. And then if you look all the way to the right side of the graph, you see how much it increased after COVID-19 had started. And then you have other studies which basically did the same thing, where they looked at pre-COVID completion rates and then post-COVID COVID-19 completion rates of advanced directives. In the United States, the most popular advanced directive form or tool or instrument is the 5 Wishes form. And 5 Wishes reports that the demand for their tool increased more than 1,000%. And you hear similar reports from other apps and websites where they measured, how much more the downloads had increased since the beginning of the pandemic. So there are a lot more advanced directives being completed, but it's not just that there are more advanced directives. We also have some innovation with respect to the very design of the directives. Like they're COVID specific. So Compassionate Choices, which is a leading, perhaps the leading end-of-life advocacy organization in the United States, has an addendum for people to add to their existing advanced directive, which elicits their preferences with respect to treatment interventions that are likely to be needed for COVID-19 specifically. There's a very interesting app called Save Our Souls, SOS, which would elicit a very specific preference, which is you might, if you had COVID-19, you might want to be on mechanical ventilation. So that might be a treatment that you would want to have. But because, especially right now as we're speaking, there are likely to be triage situations where the need for mechanical ventilators outstrips the supply. It elicits people to consider, well, what if there's a younger, healthier person that needs the same ventilator? There's only one ventilator left. If nobody else needed it, then I would want it. But if somebody else needs it, then I don't want it, right? It basically elicits the preference that you're willing to give up your seat in a lifeboat. So we have these special kinds of advanced directives that we never really had before. All of this is being accelerated by some other innovations. And those are legal innovations, right? This increase in advanced directive completion is being facilitated by changes in the law. So advanced directives generally need to be either witnessed or notarized in order to make them valid. But the law has become a lot more flexible with respect to how that gets done. And it's become flexible in 2 key ways. With respect to who can witness an advanced directive, but also with respect to how they can witness that advanced directive. So with respect to who, in many jurisdictions, healthcare providers are not eligible to witness a patient's advanced directive, right? So the people that are treating you, or employees of the hospital, or employees of a long-term care facility, employees of a nursing home, the traditional rule is they can't be witnesses, right? So in California, for example, the statute says none of the following persons may act as a witness. And then it lists all different types of healthcare providers. And the rationale typically provided for that prohibition has been that they have a conflict of interest, that they shouldn't have a say in controlling who gets to make the decision or what decisions are made when they're the ones that are going to be carrying out those decisions. But the problem is with COVID-19, with social distancing, and many facilities don't even allow visitors into the facility where the patient is, that the only people around are healthcare providers. So we have some flexibility. So the largest healthcare system in the United States is the Veterans Health Administration, and which is run by the federal government. And what they did earlier this year was they published new regulations, and those say basically that we're going to remove, because of COVID-19, we're going to remove the bar on employees of the Veterans Health Administration serving as a witness for an advanced directive, because that prohibition is an unnecessary burden to the completion of advanced directives. And there's other examples of people removing that prohibition. Now there's flexibility not only in who can serve as a witness, but also in how they can serve as a witness. So in terms of how, traditionally, the witness needed to be in the physical presence of the principal, in the physical presence of the person signing the advanced directive. But of course, in a time of social distancing, that's very difficult. So at first, a lot of lawyers and law firms got creative, and they started having drive-through witnessing, or where you come through and the person would be outside, you'd be in the car and they'd be outside the car. But more effective has been many jurisdictions have now allowed remote witnessing. So the witness doesn't need to be in the physical presence of the person signing their advance directive. They can watch the person sign their advance directive through Skype or through Zoom or an app like that. Also, some jurisdictions require that the advance directive be notarized instead of being witnessed, or some jurisdictions allow you to notarize the advance directive instead of witnessing it. And again, though, the traditional rule has been that the notary needs to be in the physical presence of the person signing the directive. But again, of course, that's difficult now because of COVID-19. So many jurisdictions have now allowed remote notarization, where again, the notary can witness the person signing through a video app. So to recap, right, the law in many jurisdictions has become more flexible, not only in terms of who can witness the advance directive, but also in how they can witness the advance directive. But, and this is the part I want to focus on, many of these new rules allowing this flexibility have come about through executive orders or through other laws that are temporary, right? They're just temporary suspensions of the normal law or temporary modifications of the normal law. So they will expire, right? Just like if you leave your milk out, your milk will expire, so will most of these laws. And that's unfortunate, because the inability to access a qualified witness has long been an obstacle to the completion of advance directives long before COVID-19. And so, just as an example, there are many people, older people in nursing homes or long-term care facilities who have outlived all of their family, right? They're sometimes called unrepresented patients. There's nobody, right? They don't have anybody to serve as a witness. The only people they know, the only people available are the healthcare providers that are taking care of them. So to disqualify those people from being a witness effectively means that they can't have, it makes it very difficult for them to complete an advance directive. So the problems in terms of accessing qualified witnesses have been an obstacle to the completion of advance directives long before COVID-19. So it is really worth considering carefully making a lot of these temporary modifications of witnessing rules permanent. And I do want to acknowledge that Tina Coburn, who's on the call here, has a very similar argument with respect to wills in the new a new issue of the University of New South Wales Law Journal, right? Basically saying we're having special rules with wills. Maybe we should make those modifications permanent, because the will completion rate is also lower than it should be, just like the advance directive completion rate is lower than it should be. So I'm making, I think, a similar sort of argument here. There is a fourth innovation with respect to advance directives, and that's happening with COVID-19, and that's video advance directives. So traditionally, advance directives have been written documents, right? Normally on paper, although now they can be written documents that aren't on paper. But now more people are recording their advance directives on video. And that's been growing in the time of COVID-19, because there are apps like My Directives that help people do this, and they help you store it in the cloud. There are apps like Vimtee, and there's one called Mideo, which is a more of a directed, sort of clinician-directed video. The other ones are more you record it yourself in your own way. These really help, actually, with respect to both helping improve the validity of the advance directive and making sure that the meaning of the advance directive is accurately interpreted. So in terms of validity, right? It's not infrequent that somebody claims the patient lacked capacity to complete the advance directive. There was a case earlier this year in New York with this patient. She's 91 years old, and this is her son. Her son wanted his mother removed from life-sustaining treatment consistent with her 1991 advance directive. The patient's other son here wanted something different. He says that his mother executed a new advance directive, and consistent with that advance directive, wants to live, wants to continue life-sustaining treatment. So the general rule is that a newer advance directive, a later in time advance directive, automatically constitutes a revocation of the older advance directive. So if the new the newer advance directive would control if it's valid, right? So the question is the newer advance directive valid? And the question that you need to answer to know whether it's valid is whether Arlene, the patient, had capacity to complete the advance directive at the time that she signed it. Well, to answer that question, it ended up becoming very useful that there was a video of her explaining why she completed that later advance directive. Similarly, there's a case out of California involving Sumner Redstone, who's a multi-billionaire 92-year-old. He's a majority shareholder of CBS Viacom, and he had completed an advance directive naming as his healthcare agent, the person that could make healthcare decisions for him if he loses capacity. He named his live-in companion as his healthcare agent, Manuela Herzer. But a little while later, he completed a new advance directive naming a new and different agent, effectively firing, right, Manuela Herzer, because the new advance directive constitutes a revocation of the older advance directive. Well, she didn't like that. So she challenges the new advance directive by arguing that he didn't have capacity to execute the new advance directive. So if it's invalid, then she's still the healthcare agent pursuant to the old advance directive. This goes to, obviously he's a multi-billionaire, right? So the stakes are high. This goes to court, Los Angeles, and they bring in, the top qualified expert witnesses in geriatric psychiatry to argue about whether he did or did not have capacity. But ultimately, the judge concludes that he did have capacity to complete the later advance directive. And the judge based that primarily on watching a video of the patient, of Sumner Redstone, explaining, this is why I completed this advance directive. This is what I'm trying to do. So again, the video really help the court help determine the outcome of that court case. Now, validity, of course, requires not just capacity, but voluntariness. Also, it's not infrequent that somebody claims that somebody coerced the patient to sign an advance directive. And again, video helps here because if you videotape the patient signing the advance directive, we can see whether or not she's doing that freely and voluntarily. So videos help prove the validity of the advance directive, whether that's helping show and demonstrate the patient's capacity, but also the patient's voluntariness. But videos also help convey the meaning of the advance directive and make sure that it's interpreted accurately. In other words, there's often a question that doctors have after reading an advance directive, which is, what did the patient want? And did she want it under these current circumstances that she's now in? Well, there's some now growing body of scientific evidence that shows that supplementing a written advance directive with a video leads to a more accurate interpretation of the advance directive than just having the written advance directive by itself with no video. So there's some value in video. That's been increasing, but it's worth noting that in the United States, at least, a video advance directive doesn't really have any legal status, except perhaps in Maryland and Idaho. So in only 2 jurisdictions does the video have formal status as evidence of patient wishes. So again, we have this increased use of video advance directives, and we should consider helping to encourage that and support that with the law in an ongoing basis after the pandemic. So I just want to turn now in the last unit to, because what we have been doing is looking at ways that the patient can communicate with clinicians, whether through an advance directive or through a video advance directive. But I want to look at now how the clinician can communicate back to the patient. And a key way, a key innovation here is patient decision aids. What are patient decision aids? These are evidence-based educational tools that come in two basic forms. They can be used before a clinician-patient encounter. Might be an app, might be an interactive website, might be a video, might be just printed literature. And some are used during the encounter, like an option grid, which basically just lays two options side by side and compares them. Either way, what they do is they present options to the patient clearly and graphically. So in COVID-19, again, there's been a real increase in the use of decision aids. So as an example, the Colorado Program for Patient-Centered Decisions has an aid which basically describes in very, very simple terms for the patient what is mechanical ventilation, and then prompts the patient to make choices. I want to be on a life support machine if it's available. I want to be, you know, it basically prompts you to elicits your decisions and choices. Similarly, this is one from Respecting Choices, focused on CPR, and basically just lays out for the patient in very simple terms, these are the benefits and risks of CPR, and these are the benefits and risks of having a do not resuscitate order. And all these tools they assume that people have very low health literacy, very low numeracy skills. So they present all the data in very, very graphic ways, right? So this one, for example, on the CPR, you can see just shows you how many people would survive if they got CPR, if their heart stopped in the hospital, which is only 15 out of 100, versus if you were not in a hospital, it would only be 2 out of 100. But it displays this with these little graphics, because this, in many, many, many studies, this has been shown to work really well. The Coalition for Compassionate Care of California has decision aids for a lot of different life-sustaining interventions, as do other people like the National Hospice and Palliative Care Organization. And there are video directives as well, video decision aids as well, which illustrate for the patient on the video what CPR entails, right? Shows them pushing air into the lungs, inserting a breathing tube into the patient, delivering an electric shock, right? These are all illustrated in the video. And just to give you one quick example, on the left side of this study, the doctor just talked to the patient about what CPR was. And you see about 50% of the patients then agreed to a do not resuscitate order based on just a discussion with the doctor. On the right side, those patients had the same exact discussion with the doctor. And the only difference is that they then watched a 3-minute video depicting what CPR actually entailed. And just because that's the only difference is a 3-minute video, but the DNR consent rate went from 50% up to 80%, right? Really, really big difference there. The new decision aids for COVID-19 aren't only for medical care. There's also decision aids about where to live. So if you live in an assisted living home, or should you leave the assisted living home to go live somewhere else? It helps you make that kind of decision. How do I choose when or where to interact with people? So lots of COVID-19 specific decision aids. Do they work? Yes. There's robust evidence to show that they're highly effective. We have more than 130 randomized controlled trials. Those trials involve more than 30,000 patients with 50 different conditions. They've been meta-reviewed, systematically reviewed by the Cochrane Collaboration, and there have been other systematic reviews as well. And all that evidence shows that there's 6 big benefits from using a decision aid versus just talking with a doctor. Those patients have vastly improved knowledge. more accurate expectations from their healthcare, more accurate perception of risks. They make more value congruent choices. They have higher satisfaction, less decisional conflict. Worry, did I make the right decision? Did I not make the right decision? Less anxiety. This is really good evidence that we have about the benefits of patient decision aids. So what's the problem? Hardly anybody's using them anywhere in the world. This was a German study from a couple years ago where they looked at the use of decision aids in these 9 countries, including Australia and the United States. And what they noted in the report was more work has been done on shared decision-making in the United States than in any other country. But then it also noted none of that work has really been incorporated into mainstream care. It's all in the research context. So COVID-19 has really cast a spotlight onto decision aids because there's a lot of interest in them because people are worried. So there's been this blip, right? This spike in the use of decision aids. And again, I think we should take that as an opportunity to take what's a temporary blip and try to think of ways to make that permanent, specifically by providing legal incentives for clinicians to use decision aids even after the end of the pandemic. So the questions that I asked at the beginning were, how has COVID-19 changed how patients make and record healthcare decisions? Well, some ways are we're allowing a broader types of people to serve as witnesses. We're allowing those witnesses to be remote. We're allowing notaries to be remote, and we're allowing the advanced directives to be videotaped. How has COVID-19 changed how clinicians communicate to patients? There's a lot more use of decision aids. Both of these developments increase value concordant care, help assure that the treatment that patients get is the treatment that patients want to get. Just as World War II innovations persisted after that war, we need to assure that these COVID-19 innovations persist after the pandemic. So thank you. I will stop sharing. Oh, and I forgot to do something. This will only take a second. I was going to do a poll. So I thought, well, this is going to be self-explanatory. So it's basically, do you have an advanced directive? And then the choices are just yes, and I had it before COVID-19, or yes, I completed it during or because of COVID-19. About half okay, now it's more than, now it's 2/3 of the people voted. Okay, well, it's slowed down, so I'll go ahead and close it and share this. So you should be able to see that. So that's consistent with, I guess, the sad data that I reported. Wait, so I should say, because I feel I have to say this, you should all go get and complete an advanced directive, right? Everybody on this call appears to be an adult. And the general recommendation, you know, from bioethics or from palliative care or from critical care is that all adults should have an advanced healthcare directive. And I have, let me see if I can, do the other, I had a, stuck. Okay. So let's see if I can, let me just do the other one. This should be quick. So the other is, how familiar are you with patient decision aids? And this is just a Likert scale from not at all familiar up to extremely familiar. Okay, so that's slowed down, so I'll go ahead and share that. So that's actually, it's pretty evenly split, which is good. I mean, oftentimes so some people are moderately familiar or extremely familiar, which is good to hear. And then I just had one more quick one here, which is, this one's a little bit different. This one is about, have you used one? Either yes as a patient, yes as a clinician, or both as a patient and a clinician. Okay, so again, overwhelmed. I mean, of course, what we don't know is maybe you never actually needed healthcare, so you never. But so there's the denominator is itself small. But actually, it's great to see that some people have used decision aids both as a patient and as a clinician, but generally not. Thank you for indulging me with that. So I think Alex is going to moderate, right?
Yeah, that's correct. Thank you very much, Professor Pope. So we've got a few questions coming through the chat. So the first question is, witnessing documents when patients don't have capacity is a huge issue and causes major problems. What is the answer for a simple mechanism to determine capacity before a document is signed?
So, the general rule is that people are presumed to have capacity. This is a big messy area actually, because advanced directives, at least, we've made it easy, right? Because we want to make them accessible. So we're always balancing between the safeguards of making sure that they're legitimate, that there's no fraud, and that the person really had capacity on the one hand. But on the other hand, if we have too many safeguards, nobody's ever going to complete an advanced directive because it's going to be too difficult. So at least in the United States and in many other jurisdictions, we don't have any mechanism for assessing capacity before an advanced directive is completed, because we allow lay witnesses, right? So it's just people who happen to be nearby, and they have no special clinical skill or ability to assess the patient's capacity. So generally, we don't do that. There actually is an increasing call for doing that, because there's a big and renewed emphasis on what are called dementia directives. So they're advanced directives specific to dementia. And many times the person completing the directive is already in the early stages of dementia. For example, an Alzheimer's on the fast scale, stage 1, 2, or 3. And therefore, there might be some question about whether the patient had capacity at the time she completed a dementia directive. So for those directives, it actually is often recommended that you have a clinician. It doesn't have to be a psychiatrist or psychologist, but at least a clinician that has some experience assessing capacity, confirm that the patient has capacity at the time of the advanced directive. But that still, as of right now, is by far the exception, that we actually have a clinical assessment of capacity at the time of signing.
Thank you for that. Another question. How is this issue, I assume the broader issue with advanced healthcare directives and things like that, addressed for people with low English proficiency and who may need interpreters?
So that's a great question. So I'll speak just for the US situation. 10 years ago, in 2010, President Obama signed the Affordable Care Act, and under regulations implemented as part of the Affordable Care Act, what we call Section 1557 of the Affordable Care Act, 1557, Those regulations require that for every patient with limited English proficiency, the provider at their own cost must provide a qualified interpreter or translator. And often that's remote, right? Because many facilities aren't going to keep, a whole range of people who know Chinese and 10 other languages on their site. So for everything that's done, whether it's relaying diagnostic information, whether it's a treatment decision, whether it's discharge instructions, or whether it's completing an advanced directive, all healthcare facilities that take federal money, U.S. federal dollars, which is basically all healthcare facilities in the country, must provide a qualified or certified interpreter or translator. So there should be some confidence that somebody completing an advanced directive in a healthcare facility, at least, got the requisite qualified help to do that. I should note that, of course, there's a massive non-compliance rate with that law, but at least we put the law in place, and we are if there is a Biden, we don't know who's going to be the president, but if there's a Biden administration, there's some expectation that that will be more vigorously enforced.
The next question expresses interest in how patient decision aids are being created. In your experience, is it hospitals/institutions, clinicians, or researchers who are driving these? There is a real contrast with the apps for ACP, which you described, which appear to be more privately driven.
So it's a real marketplace, meaning there's a lot of people developing decision aids. So some of the biggest developers in the United States are Dartmouth and the Mayo Clinic and the University of Colorado. There are a lot of private companies, like publishing companies that are developing. So it's coming from private industry, for-profit industry. It's coming from academia, because we've given out billions of dollars in grant money through AHRQ and PCORI, the Patient-Centered Outcomes Research Institute, to develop these things, right? So we've given out tons of grant money. The UK, NICE, has given out a lot of grant money. So we have a lot of decision aids coming out of the UK, and we have a lot of decision aids coming out of Canada at the Ottawa Health Research Institute. So on the one hand, the answer is many people are developing decision aids. So that's good, right? There's actually a downside to that, which is some of them are probably biased and are plagued with conflicts of interest. So if you can imagine that if a company that manufactures, like here in Minneapolis, Medtronic, which makes pacemakers and cardiac devices, might fund the development of a decision aid that basically steers people who have cardiac problems to getting a pacemaker or to getting, and that's not good. So what we really need is an organization that certifies decision aids, right? And make sure that the information in the decision aid is accurate, is up to date, is free of conflict, is free of bias, and presents the information in a clear and understandable way. It would be the equivalent of the FDA in the United States, or I forget the name of the Australian entity, but the same way that we vet to make sure that drugs are safe and effective before they can be marketed by a pharmaceutical manufacturer. We need an agency to approve and certify patient decision aids, because the answer to your question is there's too many decision aids, and some of them are garbage, and we need somebody to tell clinicians which ones are valid and which ones they should actually use.
Thanks, Dad. This is more of a comment which you may want to comment on. I agree that older people should have an advanced care directive, but never thought about one for the younger or middle-aged people, specifically related to a COVID-19 environment. I suppose that is because the pandemic is somewhat contained in Australia, along with mortality and morbidity.
Yeah, well, I mean, yeah, I think, well, I'll tell you two things. First, the typical response, at least in the US, right, is all of the most famous, the most, in jurisprudence at least, the most famous cases of problems that arose because the patient didn't have an advanced directive were all young women, right? Like historically, Nancy Cruzan, Karen Ann Quinlan, Terry Schiavo, right? These were women on life-sustaining treatment, and there was a conflict about what should we do for that patient. So at least just from a historical perspective, or at least from what are the cases that are most salient, they're all actually very young people. And I think that often illustrates the point that people who develop advanced directives advise people to say anybody can become incapacitated. Yes, statistically, it's far less likely for somebody under 60, but it's so easy to complete an advanced directive, so that the burden is so light and the potential benefits are pretty significant, that why not do it, right? And I should say, right, the key thing to do in an advanced directive is primarily appoint the agent, right? You maybe don't need to get into, do I want CPR? Do I want mechanical ventilator? Do I want artificial nutrition hydration? That's probably too much granular detail. But who do you want to make decisions on your behalf should you lose the ability to make decisions for yourself? It's just a name, right? A name and a phone number. That's pretty easy. A name, a phone number, and 2 signatures. So it's about a 5-minute ordeal to get that done. So, and that would be a lot of help, because if you talk to people who are on hospital ethics committees, and if you talk to palliative care clinicians, they frequently get consulted on, we don't know, there's a conflict between 2 daughters, we don't know who it is, and they differ, right? It would have really helped if the patient had told us who she trusts the most, who she wants to make healthcare decisions on her behalf.
Thanks, Dad. I am conscious of time, and some people I think are starting to leave. So just a couple more questions, and then we'll finish it off there. And I do apologise for those who may not have their questions or all their questions asked. So this question is from, I assume, a practitioner of some kind. In my experience working in health, most practitioners prefer not to witness documents, and having that expectation on them can be quite onerous, particularly where capacity is an issue. In Queensland, my understanding is health practitioners still cannot be witnesses. Is this an area that needs regulation? How does it work in the US?
So, like I said, that is the default rule, right? That's the general rule in the United States, is that healthcare practitioners cannot be witnessed, and that would be everybody, right? That would be physicians, licensed clinical social workers, everybody who's an employee of the facility. So even the chaplain would be disqualified. But as I said, that would map on, I think, to what whoever the questioner's experience. But there's a big push to reconsider that, both in the academic literature, because it's not clear how much value that rule the prohibition had, and at the same time, what we do know, we don't know what the benefits of the rule are, but we do know what the costs are, which is it's limiting a lot of people from completing an advanced directive. So the academic push to reconsider the rule is pretty strong and pretty loud. And like I said, some states have reconsidered that rule, and the federal government reconsidered that rule in changing the Veterans Health Administration by lifting the prohibition. It's happening very slowly. So the dominant position is still that healthcare practitioners cannot witness, but we're slowly moving away from that.
All right, and final question, which I think is a good way to wrap it up. to have some of these innovations stick post-COVID would be great. As a group of people interested in bringing around positive change in this area, those of us watching this seminar, do you have any thoughts on how we as academics and others can help do this?
Yeah, that's a great question. So what I didn't do, I mean, maybe just make a quick pitch, right? And I suspect that most of the people on this call perhaps already know this, but the quality of informed consent, and it's not going to, both Australia and the United States is just abysmal, right? Meaning patients don't, I mean, so the law is over here, right? So you can go pull your appellate court decisions. You know, in the UK, they have the Montgomery decision, and everybody's, you know, really happy about the Montgomery decision. But in practicality, at the bedside, right, patients aren't really getting the information that they need. They're not, and even if they do get a disclosure, it's not presented in any way that they really can understand or digest or process. So really what we have is patients don't really get to make sure that the treatment they're getting matches their preferences and values. That, of course, is an affront to their autonomy and their self-determination. One, it costs a lot of money. So we're wasting a whole bunch of money because we're delivering a lot of healthcare that the people getting that healthcare don't even want, right? So it's an incredible waste of money as well. So the evidence on decision aids is really powerful because it means that the patient is getting a source of information separate from the clinician that's actually treating them. And I think the case to regulators, you know, to say, to actually, we could do three things. We could mandate the use of decision aids, right? You could say, hey, doctors in Queensland, you have to use these decision aids. And you would start with the ones for the most value discordant treatment, right? The places where we think where we highly suspect that patients are getting badgered or not really well informed. Or if you don't want to put a straight up mandate, you could at least provide incentives, right? Provide some kind of legal safe harbor. If you use the decision aid, it's very unlikely, you know, we'll make it basically impossible for you to be sued for breach of informed consent. It basically gives you safe harbor legal immunity. Or we can provide payment incentives, right? We'll give you some kind of bonus or payment incentive, either as a penalty or as a bonus for the use or non-use of decision aids. But I really think it would be great if people could at least push this idea of using mandate tools, liability tools, or payment tools to help incentivize the use of patient decision aids.
Well, thank you very much, Thad. And thank you everyone for coming here and participating today. I think we'd all agree that it was an insightful and informative discussion, and I hope everyone benefited from it. I'd particularly like to thank, again, Professor Pope for contributing your time and your expertise. We're going to be running the QUT Global Law, Science and Technology Seminar Series again in 2021. So thank you everyone who's participated, and I hope to see many of you again next year. Thank you.